My name is Carrie Anders, and I'm the medical director of the Duke Center for Brain and Spine Metastasis. And I'm pleased to be here with my colleagues today to have a lively discussion about the management of brain metastasis arising from breast cancer. I'll let each of my colleagues introduce themselves, starting with Dr. Malesko.
Hi, I'm Michelle Malesko. I'm a breast medical oncologist at UCSF in San Francisco. And my primary interest in research is in CNS metastases, specifically leptomeningeal disease.
Excellent, excellent. Dr. Lynn?
I am Nancy Lynn. I'm a medical oncologist at Dana-Farber in Boston. I direct our metastatic breast cancer program and our program for patients with breast cancer brain metastases.
Excellent. And Dr. Braunstein?
Hi, I'm Steve Braunstein. I'm a radiation oncologist here at UCSF, and I have a focus in treatment of primary and metastatic CNS malignancies.
Excellent, excellent. So we've got a lot to cover today, but just to give kind of a broad overview of what we plan to discuss, we want to talk about the general management of brain metastasis, both from the local therapy perspective, but also the systemic therapy perspective, and how these modalities can be integrated together for best outcome for our patients. And also addressing brain metastasis that are stable upon decision-making and those that are active or progressing at the time of medical decision-making. And I'm also hopeful to have a discussion around the challenging clinical scenario that Dr. Malesko has just described in leptomeningeal disease. So certainly this can be conversational, and we can bring in cases of our own, but I think I'd first like to start in HER2 positive breast cancer. I think we are becoming more and more familiar with the many tools in our toolkit, and that's been a wonderful addition, but also sometimes kind of challenging to know which tool to pick when. So wanted to start just sort of your, thinking about, and Dr. Braunstein, maybe you can describe a little bit about how you approach that patient who comes in. I'm just going to say on, let's say, maintenance trastuzumab, pertuzumab, they've already been diagnosed with metastatic disease, have been doing well extracranially, but present with new brain metastasis. And in this setting, we'll say, maybe, less than 10. So sort of how you might think about that when you're approaching that patient in clinic.
Absolutely. I think first and foremost, it's very much an interdisciplinary discussion that even though my focus, for example, is on treatment of brain and using radiation techniques, I reach out to my colleagues such as Dr. Malesko to really think about not just the local issue, but the more broader issue. And our focus, of course, is from a patient-centered approach. So we're thinking about quantity of life, local control, and quality of life. And that's a big part of these discussions in this day and age, because as you know, there are a number of tools available. I think historically, we've moved towards more focal therapies. And so for patients who have limited burden of brain metastases, as you noted, less than 10, and have a good functional status, we really would put older techniques like whole brain radiation off the table, because we know of the subacute and late sequelae of that can be frankly devastating, just in terms of the impact on cognitive function and quality of life. We also have emerging data that's largely retrospective, but some prospective studies as well that suggest that it's technically feasible to offer focal radiation to patients with brain metastases that are greater than 5 in number or so, especially if they're not high volume. And it can be very, very effective at controlling the disease. Not that there aren't risks of radiation-related injury, even with our focal ablative stereotactic techniques. So we think about, from a patient perspective, are there alternative therapies that we could potentially employ, systemic therapies with CNS penetrance that may be able to control this disease, especially for patients who would have perhaps very small volume punctate lesions, asymptomatic. But our primary resource in our toolkit would be the use of focal stereotactic radiosurgery for patients as you're describing.
When When might you reach out to your neurosurgical colleagues when meeting a patient? What would be your kind of decision tree as to when you might contact neurosurgery? It sounds like, you know, very similar here. Medical oncology, radiation oncology communicate on a very regular basis, but also curious when you might pull the third modality in of neurosurgical resection.
Absolutely. I think we as radiation oncologists perhaps have the closest relationship with our colleagues in neurosurgery. In most centers, they're very much involved in the practice of radiosurgery. But first and foremost, when we're evaluating a patient, we're thinking about the location of the lesion, the need for tissue. In some cases, in some instances, this is a de novo presentation of metastatic disease, and there's value in that tissue. There may be value, even if this is not in a de novo presentation, to acquire tissue in so much as perhaps there might be molecular information that's valuable, as these tumors can show some genetic drift over time. But first and foremost, it's for patients who perhaps have larger lesions with symptoms where neurosurgical intervention and resection could immediately relieve mass effect and address any symptoms. Those are the patients that we're most likely reflexively to engage our neurosurgery colleagues. Of course, they have to have good performance status and be good operative candidates. But in this day and age, as a radiation oncologist, perhaps as a medical oncologist, my reflection is I'm amazed at how well patients do following neurosurgical procedures, especially in high volume centers. So you can take patients, even who are a little bit older, maybe have been through a fair amount of prior treatment, and they can do quite well with neurosurgical approaches. And again, not in my area of expertise per se, but the neurosurgical approaches are also evolving, both with motor mapping and eloquent area mapping and lit approaches. And so I think we're seeing perhaps improved patient outcomes with neurosurgical approaches. But again, those patients who have a larger lesion that's symptomatic, I think nothing beats the ability to immediately relieve and decompress with certain surgical approaches.
No, that's fantastic. And I would say very much in line with our practice here. I'll turn to Dr. Lin and kind of ask a two-part question. Anything to add from the local therapy approach? And then also, envisioning that this patient travels across the United States from California to see you in Boston, what would be your discussion around systemic therapy for a patient who's just received local therapy, but on the trastuzumab, pertuzumab backbone therapy prior to arriving?
Yeah, so I think in addition to the considerations that Dr. Brownstein mentioned, I'm looking obviously at their extracranial disease. And what I'm trying to think about is, is there some reason that I want to switch this person's systemic therapy? So, for example, if at the same time there were, a couple brain mets discovered, a patient had progression of their liver mets, then I'm going to be switching their systemic therapy anyways. And so in that situation, if the brain mets are not in, locations where I'm worried that a small amount of progression is going to lead to some very bad outcome, I might just defer radiation with the blessing of the radiation oncologist patient and, just switch their systemic therapy because that might work. Now, on the other hand, if somebody has controlled extracranial disease and they have 3 brain mets, then I'm going to send them for radiation because I think from a quality of life perspective, 1 day of SRS or radiosurgery and then continuation of HP, I think is optimal for patients' quality of life rather than switching them to some more toxic chemotherapy, containing regimen. And then the place where that's the gray zone is, so let's suppose somebody has 8 or 9 brain mets and they're technically potentially, able to be treated with focal radiation. And I agree, like in these HER2 positive patients, we try as hard as we can to kick the can down the road in terms of whole brain radiation as long as possible, because we don't want people to have long-term complications, and these are the patients who survive the longest. But when you get up to sort of a larger number of brain metastases, I think the question that we debate, and the patient's very involved in this decision making, is do we offer SRS to multiple lesions and then leave people in HP, or do we just switch systemic therapy in the hopes that that would treat both what we can see and micrometastatic disease that we can't see, and maybe delay the time to new CNS lesions? And it's never been a randomized trial to look at this, so it is very much a little bit of clinical judgment and some not exactly guesswork, but you're trying to play out the potential, the likelihood of different options and different possibilities, and then patients have different preferences as well as to which option that they would prefer to go down. So I think that would be the nuance that I would add there, in that sort of multiple lesions that are technically SRSable, but maybe start to feel a little bit out of the comfort zone. That patient, if I'm going to SRS and then switch to systemic therapy anyways, I might just skip the radiation and see if the systemic therapy alone is enough. But again, for those patients with a smaller number of lesions, I would routinely just have them have, see radiation oncology for SRS.
And when you're,
oh,
go
I'm
ahead,
sorry.
Dr. Mosco.
I was going to mention, Nancy, that's exactly, one of the challenges I think that I face at least, once a month or so, is a patient that has had SRS to a few lesions, is stable systemically, and we're getting, they're on the MRI every 3-month train. And so we're getting those MRIs and we see, the next MRI has 1 or 2 more brain mets. And it's always, in the past, before we had such good choices in terms of systemic therapy, would just send them back to radiation oncology. And generally that's my preference. I'll send them back because that 1 day of treatment is easier than putting them on a brand new systemic therapy. But I guess after you get 2 or 3 MRIs in a row where you're seeing, okay, one pops up here and one pops up there, then you kind of feel like you're playing whack-a-mole. And at that point, I do, start to think about, the systemic therapies. And, this isn't, I'm not sure, I'm sure this is where you were going next, Carrie, in terms of your questioning, but in terms of, the choice of systemic therapy, next, we have, the, NCCN guidelines and the FDA approvals for, various agents. And, things are going to be all mixed up with new data from, trastuzumab deruxtecan and tucatinib. But I'm curious to hear from, either, Nancy or you, Carrie, about if, you have a patient that has been on maintenance HP and you decide you need to make a change in treatment, and they're stable systemically. I think we were inclined to sort of, obviously be jumping over Kadcyla and, putting them on tucatinib and capecitabine, but now there's, not randomized clinical trial data, but very good, extrapolatable data for, for Enhertu, and with Enhertu showing such amazing outcomes in terms of systemic control and long-term, outcomes. What are you choosing? Are you jumping? I mean, I think, a year ago, we would have all said, let's go to tucatinib, capecitabine next. But now, I think I tend to lean more towards, Enhertu, or, I guess we should stick with brand names, trastuzumab deruxtecan. So I'm curious to know what your thought process is.
No, I completely agree. I think this is one of the key questions. And I think this is where, really trying to determine, is the disease stable in the brain, or is the disease progressive in the brain? And sometimes that's hard to really determine, particularly with, we sort of deemed a stable versus an active. And you could argue that, the patient who every 3 months is having a new lesion might very well be active, even though, it's stable right after radiosurgery. So, I think that, to your point, Dr. Len, it's you don't feel good about that, right? You just, there's just a gestalt that it's time to change systemic therapy. But I do feel like, and we just recently put out an update on the ASCO guidelines, both for HER2 positive metastatic breast cancer and in the brain metastasis setting. And this was one of the key questions. I think the Destiny Breast 03 study clearly showed us that trastuzumab deruxtecan was superior to T-DM1. And in that study, there was a pretty sizable number of patients with brain metastasis that were deemed stable at entry. So in that setting, I think we have some choices. I think we could, and a lot of times this depends on the patient in front of you, right? I mean, if you feel that oral therapy compliance is just not going to work with that patient for whatever reason, then tucatinib's probably not the the right direction. If the patient has some sort of underlying pulmonary disease and you're worried about their tolerance to trastuzumab deruxtecan, of course, so all these issues are kind of, you're taking all of these issues into consideration. But I think in the stable setting, I'm very comfortable with trastuzumab deruxtecan or the HER2 Climb tucatinib capecitabine trastuzumab regimen. I think in the active brain met setting, we have randomized phase 3 data based on HER2 Climb for the tucatinib regimen, and we have emerging data with trastuzumab deruxtecan. And I think not hundreds and hundreds and hundreds of patients, but upwards of 50 to 75, where we've seen very nice intracranial responses to trastuzumab deruxtecan in the active space. But I do really feel like in the active space, I'll tend to go toward tucatinib if everything else is equal, and then also have trastuzumab deruxtecan for next line therapy. So that's sort of how I've been thinking about it in my head. Dr. Lynn, I'd be curious to hear your thoughts as well.
Yeah, I've thought of it the same way. I mean, I am convinced at this point that trastuzumab deruxtecan has CNS activity. I think, the studies have been small, but there have been multiple studies from multiple groups, all, showing CNS responses. So to me, that's not really so much in question. But I think what drives my thinking is that, in the HER2 Climb study, which is a randomized trial, you see that it delayed time to CNS progression and improved overall survival. And the survival benefit was not trivial. It was a 9-month absolute improvement in overall survival in the brain met subset, and similar in the active, and that was for all brain met patients, and then a more than 9-month delta in the active brain met patients. And that's not the median survival, that's the actual absolute, delta, which is really dramatic. I mean, if you saw that in a typical metastatic trial, it would be really dramatic, and it's really dramatic in brain met population. And in Destiny Breast 03, we don't have any data, and it's not been reported, CNS progression-free survival. The overall survival data are not mature, and certainly not enough patients in the brain met subset, plus the lack of maturity to really have a signal to know one way or the other. So to me, at least at this point in time, there's you've got response data, CNS progression-free survival data, and overall survival data with tucatinib, and that's why I would tend to choose it in that second line setting right now. Now, if a patient had stable brain mets and their problem was extracranial disease, I would for sure, unless there's a contraindication, go for TDXD. I think the data there are so strong in DB3. But, I think for the other types of brain met patients, I tend to more lean towards tucatinib. I think that may change over time as we see more data emerge with TDXD in the brain met population. But for right now, I think the data are stronger for tucatinib.
No, completely agree. And, to kind of think about the case a little further, and I know unfortunately we've all seen this in our practice, is after sometimes years of stability in the brain, our patients develop leptomeningeal disease. And that can be very challenging. So I first wanted to start with Dr. Bronstein to see sort of what his approach from a radiation oncology perspective would be. When do you consider whole brain? Do you consider whole brain in patients who present with LMD, and then kind of talk through some of the systemic therapy options that we have?
Absolutely. I acknowledge that it is a very challenging clinical situation. It's also a situation that can span a spectrum of presentation. There are some folks who have a very significant symptomatic burden of leptomeningeal disease, and others who may have some radiographic presentation, but without the sort of overt symptomatic component. And because of that, we address it accordingly. And we're thinking, maybe in this instance, more so than ever, really about interdisciplinary and patient-centered care. So I think a patient should have a very strong voice when we talk about these very comprehensive or aggressive therapies. But historically, whole brain radiation was employed to treat rather symptomatically without really much benefit in terms of overall survival, in part because it's not a local problem at that point. Now, interestingly and timely, there is some emerging evidence that if we direct the therapy along the entire craniospinal axis, which is a very comprehensive type treatment for some patients, as compared to more focal what I'd call whole brain or involved field, there is a benefit. A phase 2 randomized trial demonstrated that there's a benefit perhaps to what was proton-directed craniospinal radiation for these patients. And that's provocative, but really the focus of that trial was frankly on CNS progression, overall survival. There's also the question about quality of life. Now, these patients lived, up to 10 months or so, and I would argue that that is a substantial potential, survival from the time of treatment. But of course, it's not curative, and the durability is still questionable. And I think one of the really interesting questions is not just in the treatment for patients who have overt leptomeningeal, but can we stratify? Can we identify those patients, as we're discussing, who maybe they don't have stable brain metastases, but with some cadence, we're seeing more and more burden of disease? Is there a time where perhaps we could intervene with some comprehensive treatment or combination radiation and systemic therapy to perhaps avert the presentation of true leptomeningeal disease? And I think that is an area of opportunity now in the combination of these proven CNS directed radiation techniques and CNS penetrant therapies. So it doesn't answer the question altogether, but really we're looking to avoid having that question come up and being able to treat earlier and make a bigger impact in terms of the trajectory of the disease.
No, that's fantastic. And I had recently seen, as you said, that provocative data of the proton therapy along the entire neuroaxis. I think it'll be really interesting to see how that data plays out and how it can be also disseminated, across other centers. Dr. Malesko, with your interest in LMD, what would be your approach for a patient with HER2 positive disease? And we'll just pretend that the patient is therapy naive, or you can kind of think through, like, if they've received certain things, what you might be considering, because we all recognize that many patients come to us with a very different treatment history, and you have to adapt your thinking based on what the tumor cells have already been exposed to systemically.
Yeah, I mean, we participated in the TBCRC49 study, as did Dr. Lin, with tucatinib, the HER2 Climb regimen, and did see, good outcomes. I mean, for leptomeningeal disease, what you would consider, reasonably good outcomes for patients receiving this systemic therapy regimen. But I think it all gets back to, how do these patients present? There's, sort of a big difference between someone who is getting their brain MRIs for follow-up of parenchymal brain mets, and we see a little bit of leptomeningeal enhancement. And in my practice, I mean, I think in the past, we were all kind of hesitant to do the LP and prove LMD, because then when you did prove it cytologically, then the patient was excluded from everything. I mean, every trial would exclude someone with LMD. Now, I mean, I do have a tendency to do more LPs, partly because of research interest in collecting those cells and looking for cell-free DNA and looking at immune profiling, the stuff that we're doing, as well as I know that they're, doing in Boston, and that you're doing as well, to try to be able to do that risk stratification, which I think really is going to be, in some ways the future for patients that have these parenchymal brain mets that we're picking off with SRS, to see if we can learn something, either through biopsying by LIT, as Dr. Braunstein brought up, getting a biopsy during a LIT procedure, or looking at CSF as a surrogate for what's going on in the brain. But if a patient presents, with relatively asymptomatic LMD that we pick up incidentally, I will almost always go to the HER2 Climb regimen first. So try tucatinib, capecitabine, and trastuzumab. But if they're more symptomatic and they, have dizziness, and if there is clearly an area of the brain, we pick up a lot of stuff in the internal auditory canal with patients presenting with, tinnitus and vertigo. And, I do think that, a combination of some focal radiation and it might end up meaning, whole brain or cerebellar radiation, and then, starting some type of systemic therapy like the HER2 Climb regimen. I was, very enthusiastic about intrathecal Herceptin, was involved in, the intrathecal Herceptin studies, trastuzumab studies. And I think that I had some patients with great responses, but, it is a labor of love, to do intrathecal therapy. twice a week for a couple weeks, for a month. And, if it doesn't clear, you need to go longer with a twice a week dosing. So that is a challenge. I do believe I do use it. But if I try the tucatinib first and it isn't successful and there's no more radiation options, if someone's already had whole brain, then I will try intrathecal trastuzumab. And, I have also, there are case reports for neratinib. So, I did have one patient that actually developed some abnormal liver function tests on tucatinib when I was trying to treat them for leptomeningeal disease. And so I switched to tucatinib, cross fingers so far, they're stable so far. And then, I do think that we've talked a lot about, HER2 positive breast cancer, but, more and more in the LMD space, I'm seeing a fair number of patients. Of course, we see it with triple negative patients, but they have this all often combined with, massive systemic progression. But a challenging group for me has been the ER positive patients that are, 10 or, 5 or 10 lines of therapy in, especially the invasive lobulars. That has been a group of patients that I have had multiple cases of LMD in the last year. And those are really, I feel like, this unmet need where, going back to, radiation, we don't have as many good, systemic therapies. Maybe, if we actually identify more mutations, maybe those patients with lobular cancers that have a high rate of HER2 mutations, we might be able to use neratinib in that space, or other TKIs, emerging. But I think that, I use all of the tools with LMD for HER2 positive. It's just it's the HER2 negative that I'm, most challenged by. And so I wanted to go back and ask Steve a question. So what about a patient that has had, for this, someone you're thinking about craniospinal irradiation, what about someone who had like radiation to an isolated vertebral body, 3 or 4 or 5 years ago? Because almost all of our patients, a lot of them do. How would you consider, doing craniospinal radiation in someone who's had part of their spine previously irradiated? Can that be done?
Yeah, that's a paramount consideration, because we need to be mindful of what we're technically able to achieve in these patients, and certainly don't want to do any harm, because any radiation-related injury to the spinal canal could be devastating. There are some techniques that can be employed to try to be as thoughtful and conformal as possible, but you cannot stop having overlap in some cases. And so we need to be mindful of what the dose thresholds are, the time between treatments, and also recognize that many of these patients you're describing maybe in a very heavily pretreated background, which can affect sensitivity potentially to radiation, especially if they've had intrathecal therapies like methotrexate, for example. So it can be limiting. I think that's fair to say in terms of what we can technically achieve when we're re-irradiating these patients. But one of the considerations, and so much as often in the metastatic setting, we're treating these patients up front for palliative osseous-based lesions, we can be mindful at using techniques to minimize dose to the actual cord, because that's not where the disease is in the upfront patient who has a T8 vertebral lesion. So we do have the techniques to be able to minimize dose to the actual cord, so that we spare some threshold to potentially employ later in this type of situation.
Oh, that's fantastic. And I think we all we're recognizing, just as Dr. Len said earlier, our patients are living longer, which is fantastic. And so that makes our consideration of our therapies even that much more important in terms of mitigating the toxicities down the road, which is a challenge, but a wonderful challenge to have, right? So Dr. Molesky, you gave a great segue to HER2 negative breast cancer metastatic to brain. And I'd love to just hear from Dr. Lynn sort of what your general approach is to a patient with both ER positive HER2 negative breast cancer, as well as triple negative breast cancer, where we certainly see a high proportion of our patients in the advanced setting recurring in the CNS.
Yeah, so I think that, in general, systemic therapies for CNS active disease are much less, well developed in this setting. And so, in the situation of HER2 positive disease, there are many situations where I might be conferring with radiation oncology in the patient. Should we defer radiation and try systemic therapy first, right? For HER2 negative breast cancer patients, it's much more of a lean towards local therapy as kind of the default with, sometimes we might use systemic therapy, and certainly if there's a trial, we might use systemic therapy. So I think that's one big difference, is that we just aren't as confident about the efficacy of systemic therapies. The other is that for triple negative breast cancer, patients who have multiple brain metastases on average do very poorly. And so those are patients where we do tend to be quicker about moving to whole brain. So, a patient who has 8 lesions with HER2 positive breast cancer, we might offer SRS. A patient who has 8 lesions with triple negative breast cancer, at least at our institution, we routinely offer whole brain because our data internally has indicated that for patients who are offered SRS, their time to next CNS progression is very, very short. So I think we do kind of tailor things according to subtype in that way. And then from a systemic therapy standpoint, we just don't have as many options, and we have to be more creative. And sometimes when we're stuck and somebody doesn't really have a good radiation option, obviously we'll think about a systemic option, but oftentimes we're looking at small phase 2 studies if we're lucky, and otherwise it's a case report or a small case series, and you kind of have to go with what you have data-wise, and try to propose things. I try to propose things that have some known breast cancer activity and have at least some indication that they may have CNS activity. But again, I'm much more inclined to lean patients towards local therapy approaches if there's a reasonable one to be offered.
No, that's fantastic, and I think really highlights the difference in our approaches by the patient's tumor subtype. Absolutely. I think in my own practice, I tend to lean on, in the ER positive space, abemaciclib. Yep. As the I think of the CDK4/6 inhibitors, the most brain permeable, and I was very intrigued by the MAINTAIN data. At ASCO, which really looked at this question that we've had for quite some time, which was CDK4/6 inhibition after CDK4/6 inhibition, with some transition in the endocrine therapy backbone from an aromatase inhibitor to a SERD. And I am curious from the team if, after a patient who potentially has been on palbociclib for 3 years, if you would consider abemaciclib in that setting. I know we're in a bit of a data-free zone, but as you said, Dr. Lynn, we try to do the best that we can with the tools that we have.
Yeah, I mean, I think linking back to I think it was Dr. Maliska who talked about lobular cancer. In general, our endocrine therapies work better than chemotherapy, and so if I have a patient with lobular cancer who has a primarily CNS presentation, yes, I will switch from one CDK to another, or switch out the endocrine therapy, because, I'm really trying to maximize that endocrine therapy benefit. Whereas a person who has more like a luminal B type of cancer and doesn't do so well on first line endocrine therapy CDK4, I'm more likely to cycle that person onto chemotherapy earlier. And there are some chemotherapies with some CNS activity, including capecitabine and anthracyclines and platinums. And so there are options to consider.
No, I think those are very similar strategies that I use as well. And Dr. Maliska, I would love to hear your thought in the triple negative space. I think this also kind of dovetails with, it's hard not to talk about Destiny Breast 04 in a breast cancer forum after ASCO this year, standing ovation, amazing data. Very little data for brain metastasis in that presentation. I looked at it earlier and it was 6% of the patient population had stable brain mets, but just kind of thinking through your approach to systemic therapy in the triple negative space for patients who have CNS recurrence.
Yeah, I mean, I think that, obviously it's interesting to hear what Nancy, Dr. Lynn was saying about their approach towards moving faster to whole brain radiation, because I think, we may have a slightly different approach at UCSF, because especially if someone has really aggressive triple negative breast cancer, where we're running after, the liver mets and the lung mets, as well as the brain mets, and thinking about, long-term quality of life. And, it's true that if someone is only going to live for, a year from their systemic disease, that doing whole brain radiation, they're probably not going to suffer the long-term, cognitive effects of the radiation. But, our population just is quite resistant to whole brain no matter what.
Mhm.
So that's a challenge for us, I think, and Dr. Brownstein could probably chime in more there. But as far as the systemic, disease, there's a little bit of data for sacituzumab govitecan in the CNS, and Dr. Brenner has a SWOG trial, that's moving forward. We're not part of SWOG, so I can't speak to anything about that design, but looking at, sacituzumab govitecan and progressing CNS metastasis. I think that we have a desperate need to, be, more daring in terms of, doing, having study designs with patients with, relatively clinically stable but progressing brain mets. I mean, I think that, the checkpoint inhibitors, it looks, I've spoken, extensively with Genentech, and they've looked at their data, and, obviously atezolizumab is not on the table for metastatic triple negative breast cancer anymore, but they were pretty convinced that it wasn't an active agent. I know Dr. Brastianos has, done a small study with, pembrolizumab and other checkpoint inhibitors for patients with LND, different, obviously very different than a patient with a progressing parenchymal brain met. But I think that actually trying to dig more into what is the role of immunotherapies and antibody drug conjugates in triple negative breast cancer is just something needs to be done.
Yep.
I think no company wants to do that because they don't want to muddy the waters with patients that have a poor prognosis, which is unfortunate. So I think it's on us as investigators to try to do our bit here and there to try to promote some investigator initiated trials that are going on across the country. So, with the triple negative population, I might try sacituzumab govitecan outside the context of a trial because I might be giving that to them anyway.
Yeah.
I am a big fan of the cisplatin etoposide. It's an oldie but a goodie. There's data with, both from, Italian groups, Turkish groups, and then the Taiwanese group has published on use of that both in brain mets and leptomeningeal disease. One of the studies, had bevacizumab as part of the regimen. And, I have, used bevacizumab in the past. I know that Dr. Lin, years and years ago had, some, interest in combining bevacizumab, but, that anti-angiogenesis agents haven't, had much success in breast cancer long-term. So I think trying different systemic therapies, there is no magic bullet for triple negative breast cancer, but obviously looking for those triple negative patients that have, HER2 low status. So the, one or two by IHC, obviously, we're going to be reaching for trastuzumab deruxtecan almost. I think it's going to be, like they're going to be putting it in the drinking water. It's going to be so ubiquitous. It's going to be given to you walk in the oncology clinic and you're going to get a cup of TDXD, after that presentation. So I think, for sure I'll be biopsying more patients. And again, I keep getting back to this idea of, and I've only been, became familiar with LIT, in the last, 6 to 12 months, but, we have been, sort of remiss in biopsying our CNS, metastasis. And I think this is the future of being able to get tissue and actually do more investigation of the biology to look for PI3 kinase mutations, which I know you have looked at in terms of the responses to, therapies, looking at HER2 mutations, looking at, low level HER2 expression, as well as things like MYC amplification, which I think is going to be the potential target for triple negative breast cancers and CNS disease. So I think that's really going to be the future for that population. I think one place I still am curious, just, to hear about what your thoughts are, is that for these patients with ER positive leptomeningeal disease, I mean, we're kind of up against the wall. I mean, because, we presume by that point they've already gotten abemaciclib. I still give intrathecal therapy. I think it works on occasion, and I know that it's not very popular. I know most most oncologists don't like to do it. I wish we had more drugs and options, but I'm curious if either of you give intrathecal chemotherapy and how often you give it. I mean, I do give it.
Yeah, no, I think that's a great question. And I love your overview. And I also love your call to be more daring in our trial designs. I think the only other thing I would add from a targeted therapy perspective would be PARP inhibitors. I've had some very nice durable responses intracranially for many of largely younger, but I do have some patients, over the age of 60 we found a germline BRCA mutation, and even in some cases, a somatic BRCA mutation on a clinical trial in one of the TBCRC studies. And I think certainly in the literature, there is, emerging evidence that brain metastasis may harbor deficient DNA repair responses. And I think to your point, Dr. Molesko, the more we know about the biology through less invasive biopsies, for instance, like you're discussing through the LIT technique, which is through a small biopsy, the better, because we'll have more information on the brain metastasis biology and not sort of extrapolating from what we see in the extracranial metastasis. So, and I think just to answer your question around intrathecal therapy, I have used it, I would say, with the more recent tools that we've had, particularly in the HER2 positive space, less frequently than I had in the past. I'd love to hear Dr. Lynn's comments, and then we can probably close.
Yeah, I mean, I do use intrathecal. So for HER2 positive, if I'm going to do intrathecal, I tend to try intrathecal trastuzumab before I do intrathecal chemotherapy. Mm-hmm. In the HER2 negative patients, I do offer intrathecal chemotherapy, but I often offer systemic chemotherapy or endocrine therapy if they might have endocrine responsive disease first, mostly from a convenience standpoint, because I think the data from the IT chemotherapy trials is not incredibly optimistic, and so I don't think it's wrong to offer people first systemic options. I offer capecitabine, for example, if they haven't had it before.
Sure.
And so by the time people get to, are we going to give intrathecal chemotherapy or not? In many cases, unfortunately, the other option on the table is hospice. And so I think that does influence our use of intrathecal chemotherapy, but I do offer it. I would say that in terms of like the question about being daring, I mean, our paradigm until now has been, the assumption is drugs are not going to work in the brain until proven otherwise. And honestly, like it really should be, in my opinion, the other way around. Drugs will work in the brain unless proven otherwise. And so if we look at the ADCs, for example, I mean, we pushed and pushed and pushed many different companies over many different years. And now look, TDM1 is active in the brain, TDXD is active in the brain, probably sacituzumab is active in the brain. We'll see what the SWOG study ultimately shows, but certainly the drug levels are there. I think ADC trials moving forward, my preference would be to just include patients with brain mets up front, assuming they're going to have activity. And if they don't see activity in an early interim, just exclude them then. But, why do it the other way around? And similarly for PARP inhibitors, we have several patients actually we've treated with leptomeningeal disease with, greater than 1 year durable, dramatic responses, like clinical improvement of very serious symptoms. And there will never be a randomized or even small prospective phase 2 trial of, BRCA 1 and 2 carriers with leptomeningeal disease. That trial will never happen in a million years. And if you only let people with CNS disease onto the registration trial, there might have been like 10 patients total in the whole trial, but that would be the largest data set in the world, and it wouldn't have affected the primary endpoint at all. And so I think, I do think from a advocacy standpoint, really advocating to be more inclusive of patients with brain mets in trials is so important, because in some cases it's possible to do an IST and really show something in a small single arm type of experience that leads to changes in the guidelines, but other times it's really not, and then you end up with this kind of zone where you've got 2 published case reports, and then you practice your medicine based on that, and it doesn't feel good to do that. It doesn't feel good as doctors to do that. It doesn't feel good as patients to be told, this might work, we're going to try it for this reason. And I just think that there have been very few instances where a drug that is truly active in breast cancer has had no CNS activity. It's usually the other way around, that there is CNS. It might be less than the systemic activity, but there typically is some. And I think changing the defaults would go a really long way.
No,
well said.
Beautifully said. Yes. I think we need to move from the blood-brain barrier to the blood-tumor barrier. Yeah. And that's a very different interface. And to your point, I love the really switching the order, right? Don't exclude up front, include them and give us a reason to not want to move forward, then not look at all. Because otherwise we wouldn't have had the information that we have now, that we've discussed on this call.
Right, or, oftentimes what happens is that there's a compound that, the phase 3 has been fully accrued, and then an IST in brain mets, opens. And, that's a lot of years of excluding patients and a lot of time
Absolutely.
lost.
Well, and then you see what happens that once the drug becomes approved, then the community is not going to send the patient to put them on the trial. So it becomes difficult to accrue and
Absolutely.
miss out on that opportunity. So it's a cost and missed opportunity.
It's a really good point. Yeah. Well, thank you all so much for your collective expertise. This has been a fantastic conversation, lots to think about, and look forward to seeing you all soon.
Thank you.
Thank you.